Thank you. I think we all are aware that basically whether it's phakic intraocular lenses or regular intraocular lenses, they should be placed ideally in orthogonal astigmatism. That is where the steep and the flat axis is at 90 degrees to each other. So placing it in a keratoconus eye where the cornea is irregular and the astigmatism is all over the place is slightly controversial. Let me try to take you through the tenets of what we observe. So whenever there is stable keratoconus, which is because of aging of the patient or because the cornea has been cross-linked maybe with the topo-guided PRK or with an intact segment, then we consider it. One of the most important things that we need to understand is placing the phakic intraocular lens is not going to improve the quality of vision. At best, what it can give is a good spectacle corrected visual acuity. So ideally, if the patient is dependent on contact lenses, then for the, say, a semi-soft contact lens or a rose-K lens for visual rehabilitation, they're not good candidates. We'll also talk about centered and decentered cones. So essentially, it's a two-step approach that we go ahead. To stabilize the cone first, that is to arrest progression, to regularize the cornea to the extent possible by either just doing a cross-linking or cross-linking with topo-guided PRK or with an intact segment. Wait for a period of 6 or 12 months to ensure that the topography as well as the refractive is quite stable. And if the patient has good visual acuity with a pair of spectacles, then that patient is a good candidate for consideration for a toric phakic intraocular lens implantation. Let me take you through some case examples. The typical case of keratoconus, you can see that the best corrected visual acuity is only 6/18. There's considerable elevations inferiorly. There's astigmatism -4 diopters. And what we do here is do a CXL with topo-guided PRK to regularize the cornea. And this is what we get at the end of the treatment, where we find that the amount of astigmatism is significantly reduced. You see a more manageable bow tie in this case, and most importantly, with the spectacle correction, the patient's vision acuity improves to 6/9 plus. This is a case where, and the fact that the cone is well centered is demonstrated by the fact that the major portion of the cone is within the central 3 millimeters in the posterior float. That is the area you look for when you want to make out whether the cone is centered or decentered. So this now has been converted into a good case for implanting a phakic intraocular lens. Going on to another situation, a very extreme myopia. Please notice that the astigmatism is just 1.5. As we all know, in these cases of keratoconus, doing a good refraction and determining an endpoint itself is a challenge. The patient's best corrected visual acuity is just 6/12/N18. And after post-intacs and CXL, what you find is the myopia has come down from -13 to 7, but do not consider that as a deterioration of the condition because the astigmatism is increased from 1.5 to 4. It is just that the cornea has been so regularized, the patient is able to accept more cylinder. That is the reason that the best corrected visual acuity has gone up from 6/18 to 6/9. And again, you see a reasonably well-centered cone in the posterior cone as well as with the spectacle correction, the vision improves to 6/9. Again, this would be a good patient for placing a phakic intraocular lens. I'm not going to show this in great detail for the simple reason that the procedure itself is exactly the same as what we do. You can see the intact segment over there and the phakic intraocular lenses being injected inside. And otherwise, most often it's a toric intraocular lens for the simple reason there's a significant amount of cylinder that also needs to be handled. The lens is placed in the correct direction. And most often in the first post-operative day itself, there's a Varion overlay that's not seen in the video recording. That's the reason that the lens is being positioned without any external markings. And that's the end of surgery. In case the patient needs it in both eyes, generally we do it in about 2 to 3 days apart, just to make sure that the first eye is doing well before taking on the second eye. A normal phakic intraocular lenses, bilaterally, we'll do it on the same day. One important consideration that you must keep in mind is, as you know, as far as the sizing of the phakic intraocular lens is concerned, it's extremely important to get the correct AC depth, and this is what you would see in a normal eye. On the other hand, if you have a patient with a keratoconus, there could be a central bulge. Need not be a very regular bulge, but as you know, there could be irregularity there, because of which the central ACD could be in the range of 4.2 millimeters. But the peripherally, there could be considerable crowding. That is why if you go entirely by this measurement, and then you might have a slightly larger lens, and because of which there could be peripheral shallowing tendency for the angle to zip up, etc. What has been suggested is to take multiple measurements of the AC depth, not just in the center or on the periphery, but practically we find that doesn't help. So what we do is to essentially bring down the size of the phakic intraocular lens, and what is suggested by the conventional formula by a step or two. That is, if what is suggested is a 11 millimeter, we would go for a 10.75 or a 10.5 millimeter overall diameter of the phakic lens, and it seems to work well, giving the right kind of vault in these cases. So this is what is I want to demonstrate, in the sense that you go entirely by the central AC depth, then there could be crowded in the angles, and that could compromise the visual outcome as well as the results. What exactly are the challenges? As we already mentioned, post-implant uncorrected visual acuity can at best be similar to best spectacle corrected visual acuity. And in any case of keratoconus irregular cornea, the end point of refraction itself is somewhat difficult to determine. High astigmatism may need customized lenses. We are able to get that from our own Indian manufacturers. And so thankfully so, the subjective comfort of the patient, even though the refraction, your optometrist might have noted down -3, -2.5 diopters of residual astigmatism, many of these patients are quite happier once these lenses are implanted, as far as the quantity and quality of vision is concerned. And it should always be, we should always tell these patients, it's not refractive accuracy that we are aiming at, but by and large is debulking of the amount of refractive error. And though their reliance on spectacles may be reduced, occasionally they may require it. We did a prospective study of implanting phakic intraocular lenses in 126 size of keratoconus. We used both the toric ICL and toric IPCL. All these patients were stable keratoconus, either because of aging or because they had been cross-linked earlier, and they had to be comfortable with the best spectacle corrected visual acuity. The cone could be centered or decentered, but the patient should have had a good best spectacle corrected visual acuity. 12 of these cases had post-intacs. And the analysis subsequent to the implantation of the phakic intraocular lens was for a minimum period of 1 year. This is what you see here. The cylinder, these are all moderate keratoconus, not extreme keratoconus. The age of these patients was slightly higher than our usual refractive error patients, who are usually in their early 20s. You see they are about 30. The average astigmatism about in the range of 3.58. The Kmax was about 53.57. Obviously, patients who are still in their 60 and 65 Kmax would not be correctable with their spectacles, and they are not good candidates for phakic intraocular lenses. And what we found was that the subsequent to the phakic intraocular lenses, mind you, these are irregular cornea, the residual spherical equivalent was less than 0.5 diopters in 80% of the eyes, and less than 1 diopter in 90% of the eyes. To my mind, these are excellent visual outcome as far as this rehabilitation of these irregular corneas is concerned. 50% of the eyes, the corrected distant visual acuity remained unchanged. That is, what was achieved with the spectacles could be achieved by the phakic intraocular lenses. And more importantly, in 40% of the eyes, corrected distant visual acuity actually improved. This is also because the proximity of the phakic intraocular lenses closer to the nodal point of eye. And these are other primary 3 outcomes that we measured. Whether the outcome varied between low cylinder and high cylinder, whether between it's a toric ICL or a toric IPCL, that's the Indian lens. Mind you, we used more of toric IPCL in the higher grades of cylinder, simply because it was only toric IPCL which could be customized. And whether centered or decentered cones. Basically, our initial premise was if the cone was grossly decentered, that is outside the central 3 millimeter in the posterior float, we were not considering these patients. But some of them, in spite of the decentration of the cone, were happy with spectacles. So in the later part of our study, we included them as far as placing a phakic intraocular lens is concerned. as far as classification to low and high cylinder is concerned, most often it's considered as 2 diopters of cylinder. But for the purpose of this study, where most of these patients have high cylinder, 4 diopters of cylinder was considered, less than that was considered low, above 4 diopters was considered high. And to summarize, we found similar results both in low as well as high cylinder. And as far as the Indian version or the imported version of the phakic intraocular lens is concerned, the results were quite similar. More important to emphasize that the more higher amounts of astigmatism received toric IPCL, and whether it was a centered or a decentered cone, as far as the best spectacle corrected visual acuity was good preoperatively, these patients seem to achieve similar results. So essentially, toric phakic intraocular lenses are an effective tool for rehabilitation of these difficult cases of keratoconus, where achieving a good quality of vision and quantity of vision is always a challenge. Thank you so much.